السلام عليكم ورحمة الله تعالى وبركاته.
Walaikum salam.
Is my voice clear for you?
Yes.
Yes.
So shall we start our session with the citation with Kitab Surat Al-Fatiha? Okay, our topic today is very important topic. It's about mood disorders, which is very important topic and very common psychiatric disorder. So let me share my screen. Can you see my slides?
Yes.
Yes, okay.
Okay. So it will be a little bit long lecture because, you know, the topic is big and it has many contents. That's why maybe you will take a break of 5 minutes in between if you need, okay? So mood disorders are psychotic disorders in which the core symptom is the disturbance in emotion or mood. In mood disorders, the mood is either too low or on the opposite, elevated or sometimes irritable. And this mood is intense and persistent compared to the normal variation of changes in mood that is happened like normal happiness or normal sadness as a reaction to some events. And in mood disorders, these changes or mood changes can cause also affect the social occupational functioning of the patient and may be associated with other symptoms such as disturbance in thinking, disturbance of sleep. And then mood disorders, also known as affective disorders. Okay, so patient with only depressive episodes, major depressive episodes, is called to have or known to have a major depressive disorder, MDD, or unipolar depression, sometimes called. Patients with both manic and depressive episodes, or patients only with manic episodes, said to have bipolar disorder. While hypomania is an episode of manic symptoms that doesn't meet the criteria of manic episode. And we are going to discuss the difference between mania and hypomania later on. Then cyclothymia and dysthymia are disorders that present a less severe form of bipolar disorder and a major depression, respectively. So some points regarding the epidemiology. In World Mental Health Survey that included 11 countries, the lifetime prevalence of bipolar disorder was about 0.6%, while for bipolar 2, 0.4%. And the prevalence of bipolar disorder varied between countries. So in US, a lifetime prevalence is 1%, say 1%, and 1.1 for bipolar 2, and 1% for bipolar 1. While in Japan, the lifetime prevalence was 0.1% for both bipolar 1 and bipolar 2. Regarding depression, the prevalence of depression in Malaysia was estimated to be from 8 to 12%. based on a study done in 2014. And a meta-analysis showed that the global prevalence of major depression at 4.7%. This is a study done in 2013. Concerning the gender, in major depressive disorder, women being affected twice more often than men. And bipolar 1 disorder has an equal prevalence between men and women. And when manic episodes occur in women, they are more likely than men to be having mixed features, meaning that mixed manic, mania, and depression. Also, women have higher rate of having rapid cyclic and bipolar 2. Regarding the age, the onset of bipolar 1 disorder is earlier than that for MDD. And the mean age of onset of bipolar 1 is about 30 years of age, while the mean age of onset of MDD is about 40 years. But at 50% of all patients having onset between the age of 20 to 50 years. Moving forward towards the etiology of mood disorders, there are many factors, biological factors, psychological factors. So regarding the biological factors, one of the important points is dysregulation of biogenic amines, based on finding of abnormal level of monoamine metabolites in the blood, urine, and CSF in patients with mood disorders. For example, homovanillic acid, which is derived from dopamine, ought to be low in the blood and urine and CSF. Also, 5-hydroxy-indole-acetic acid, which is derived from serotonin, and also the 3-meoxy-4-hydroxy-phenylglycol, derived from norepinephrine. Also, studies have shown that serotonin depletion associated with depression. That's why the drugs that is called serotoninergic agents, like, for example, selective serotonin uptake inhibitors, are effective in the treatment of depression. Also, low level of serotonin metabolite is associated with violence and suicide. While studies have shown that dopamine activity may be reduced in depression and increased in mania. Other biological factors in neuroendocrine regulation. Neuroendocrine abnormalities maybe reflect disturbances in the biogenic amines input to the hypothalamus. And hyperactivity of hypothalamic pituitary adrenal axis in depression lead to the increase of cortisol level and resistance to suppression by dexamethasone suppression tests. In depression, decreased release of thyroid stimulation hormone and growth hormone and FSH, LH, and testosterone, and also decreased nocturnal secretion of melatonin. Immune functions are impaired in both or reduced in mania and depression. Regarding sleep, in depression, abnormalities may include delayed sleep onset, shortened rapid eye movement, and latency, which is the time between falling asleep and the first REM period. Also, there'll be increased length of first REM period and abnormal delta sleep. While we have multiple awakening and decreased total sleep time in mania. Candling is one of to describe the process by which repeated subthreshold stimulation of a neuron can generate an action potential. This stimulation leads to the seizures at the organ level. So mood disorders may be a consequence of candling in the temporal lobes. The evidence for this, the effectiveness of anticonvulsants such as mood stabilizers, which can be used, which is used commonly in the treatment of bipolar disorder or mood disorders, is the can affect to support this type of theory. Of course, genetic factors play an important role in the etiology. Both bipolar disorders and depressive disorders run in families, but the evidence for hereditary is higher in bipolar disorder. And the risk for both bipolar and unipolar mood disorders is increased the first-degree relatives of bipolar probands. Linkage studies showed genetic associations between bipolar disorder and certain loci in chromosome 18q, 21q, and 22q. Children of parents suffering from bipolar disorder have 9-fold increased lifetime risk for bipolar disorder compared to the general population. And heritability of bipolar disorders is very high, 85%, while for MDD, major depression, is 37%. Also, twin studies have been shown that concordance rate of 60% for bipolar disorder in monozygotic twin compared to 20% in dizygotic twin. And the risk for depression in first degree relative of profound is increased about 3-fold. Relatives of patients with unipolar depression don't have increased risk for bipolar disorder. And twin studies showed the concordance rate of 45% for MDD in monozygotic twins compared with 20% in dizygotic twins. Also, studying neuroanatomy and imaging, using imaging, CT scan, MRI, and others, shows that several parts of the brain are involved, such as prefrontal cortex, anterior cingulate cortex, caudate, hippocampus, and amygdala. So during structural imaging in depression, they found that there will be ventricular enlargement, subtle widening, hippocampus atrophy, reduction size of frontal lobe, cerebellum, and basal ganglia. While in bipolar disorder, there is asymmetry in temporal lobes, smaller dorsolateral prefrontal cortex, and increase in white matter intensities. Moving forward towards psychological factors, one of the let's say theories that explain depression is cognitive theory. So according to this theory, depression resulted from specific cognitive distortions or thinking errors that present in the person that make him more prone towards depression. These thinking errors, referred as depressogenic schemata, are let's say cognitive template and perceive an internal external data in ways that altered by early experiences. One of the example of, for example, not or all explanation or generalization or personalizations, all these are cognitive distortions. Then Aaron Beck postulated cognitive triad for depression to explain depression in 3 forms. First, about the views about the self, meaning that a negative view about self-perception. Things are bad because I'm bad. The second one is about the environment or present, this tendency to experience the world as hostile and demanding, meaning that, for example, everything has always bad. Then for the future, meaning that negative view of the future, expectation of the worst or suffering or failure. So based on this, it will explain why the CBT or cognitive behavioral therapy is effective in the treatment of depression and aiming to modifying these negative thoughts or distortions. Then learned helplessness. Learned helplessness is one of the theories that explain depression in the form of that being depression referred to the inability of the person to control the events because of previous failure. So it's based on a previous experiment done by Seligman and his colleagues, and experiment done among dogs. So it shows that they have 2 groups of dogs, and then one of the group is say conditioned to fear a tone followed fear a light followed by electric shock. It's painful but harmless. So while the dogs, or the first group of dogs that have been harnessed, exposed to this, they fear about the light, because when presented, will be followed by shock. Then compared with other group, when this group of dogs that have been already trained to fear the light and shock, placed with other dogs that never trained, They put in one let's say in one in a box or in that contain two compartments with a fence in between, meaning that the dogs can jump from compartment A to compartment B. So they surprised that the second group was never trained can jump immediately when the shock started to escape from the shock, while the first group of dogs who are trained initially and then to fear the shock or to feel the light, they didn't jump. They just sat there, showing no movement. So they become like inability to change the environment. So from this theory, it generalized towards the people when they cannot learn from their previous because of repeated failure. So they can do nothing towards to change the events. Also, psychoanalytic, Freud described internalized ambivalence toward love object or person, which can produce a pathological form of mourning if the object lost or perceived as lost. This mourning takes the form of severe depression with feelings of guilt and worthlessness and suicidal ideation. Symbolic or real loss of loved person, which is loved object, perceived as rejection. Mania and elation are viewed as defense against underlying depression. And the rigid superego serves to punish the person with feeling of guilt about unconscious sexual or aggressive impulses. Also, personality factors play an important role in the etiology of mood disorders, like those with obsessive, dependent, and borderline personalities are more likely to develop depression than other types of personalities. Of course, psychosocial stressors play an important role. Can be divided into adulthood factors, childhood factors, and recent life events. Regarding childhood factors like maternal loss and disturbance of bonding, childhood sexual abuse, poor care and overprotection parenting, and poor relationship with adults. While adulthood factors based on Brown and Harris they studied the vulnerability factors which increase the risk for depression in women. They found that having 3 or more children under the age of 14, unemployment, lack of confiding relationship or stable relationship, and loss of mother before the age of 11 to increase the risk of depression among women. Also, marital breakdown is important cause of depression for men. And of course, recent life event can predispose or precipitate to depression, such as loss of a child, death of spouse, divorce, death of close family member. Recent unemployment will increase the risk threefold. Suicide in relatives, social isolation, being in prison, and then lack of social support. All these can be considered as the etiological factors, psychosocial stressors that may predispose or precipitate to depression. So the depressive disorders can be classified into major depressive disorder based on DSM-5. With DSM-5 is a major classification system. Most of the psychiatrists are using it for classification and diagnosing of mental illnesses. So based on DSM-5, the depressive disorders can be divided into major depressive disorder, MDD, persistent depressive disorder or dysthymia, which is a mild chronic form of depression that lasts for at least 2 years, during which individual experience depressed mood for most of the day than not, with at least 2 other symptoms of depression. Then premenstrual dysphoric disorder. Premenstrual dysphoric disorder occurs 1 week before the menses and characterized by irritability, emotional lability, headache, and anxiety or depression that subsided after menstrual cycle is over. Then we have substance medication-induced depressive disorder. This is related to depression, depressed mood, or depression that is due to or caused by substance that it's known to cause depression, like for example, alcohol or medications such as barbiturate or sometimes even beta blocker. Depressive disorder due to another medical condition. This is a result to depression secondary to another medical disorder such as hypothyroidism, Cushing syndrome. Then we have other specified depressive disorder. For example, or let's say there are two in subtypes such as recurrent depressive episode, in which depression that lasts between 2 to 13 days, and that occur at least once a month. Then short duration depressive episode, which depressed mood lasting for 4 to 14 days, which is non-recurrent. Then we have unspecified depressive disorders. So, moving forward towards depressive episode, what are the clinical features of MDD or major depressive episode? Of course, the key symptoms for depression is the depressed mood or low mood, CD, and also loss of interest or pleasure in previously pleasurable activities, what we call it anhedonia. Also, there will be reduced energy, tiredness, and reduced activity. So the patient easily become tired. And there will be reduced attention and concentration, difficulty in finishing tasks, forgetfulness, and inability to make decisions. Impaired at school or work, with less motivation to undertake a project or tasks. There will be negative cognitions or pessimistic thoughts that is congruent with the low mood concerning the present and future and the past. So thoughts concerned with the present, such as worthlessness, so the patient can see the unhappiness side of every event, that they think they are failing to whatever they do. So, and also other people can see them as a failure person, and they may lead to low self-esteem and decreased self-confidence. Then thought concerning with the past, feeling of guilt. So there will be unreasonable self-blame and guilt about minor mistakes or minor events that happened in the past. Then thought concern with the future. So the patient expects the worst to be happened. They foresee the failure in their work, they're going to lose their fortune, there will be deterioration of health. So in turn, this leads to feeling helpless, then hopeless, and they believe life is not worthy to live. And this will lead to maybe they wish to die. They feel, for example, patient may say that I wish go to sleep, never wake up in the morning. Okay, so they later on maybe they have more towards active suicidal thoughts or plan. About 2/3 of depressed patients complete suicide, and about thinking about suicide, and about 10 to 15% commit suicide. So the suicidal thoughts and ideation are very high among depressive patients, and about 10 to 15% commit suicide, which is high. That's why it's very important to assess suicidal risk in a depressed patient. Depressive episode often can cause somatic or physiological changes, which we call it biological symptoms of depression. Reduced appetite lead to weight loss, and it should be significant weight loss, about 5% of body weight within 1 month. But sometimes they experience increased appetite or weight gain, which is like, for example, in atypical depression, or what we call it is the atypical features. Constipation, also one of the features of depressive episode. Sleep is also affected in depression, as either insomnia or hypersomnia. but the most common or classical one is hypersomnia. It happens during as atypical features, but usually have insomnia. So compared to the normal sleep, they will have three types of insomnia: initial insomnia, inability to fall asleep; middle insomnia or broken sleep, multiple waking up during the night; and terminal insomnia of early morning awakening, which awakening in the morning earlier, at least 2 hours before the usual sleeping or usual the waking up time. So often the patient wake up very depressed and maybe also highly suicidal, with the mood gradually lifting up during the day until it reach its best. Still depressed, but it's better than in the morning. So at the evening, but be feeling much, let's say a little bit better, but still depressed. This is what we call a general variation of mood, being worse in the morning. There is usually marked reduce in sex drives, decrease in libido, and also may have in women may have amenorrhea. So the biological symptoms of depression may include reduced appetite, weight loss, constipation, early morning awakening, or what we call terminal insomnia, the variation of mood, and reduced libido and amenorrhea. During MSE, mental state examination, the appearance regarding the appearance of depressed patient, there will be let's say generalized psychomotor retardation, and or sometimes agitation can be seen in older patients, especially stoop posture, no spontaneous movement. Depressive faces include downturned eyes, sagging of corners of the mouth, and the presence of vertical furrow between the eyebrows, poor eye contact with the interviewer, evidence of weight loss, and maybe even patient become dehydrated or emaciated. Maybe the clothes become much more too loose, jadi longer, evidence of poor self-care, self-neglect. They have unkempt appearance, maybe it's even poor personal hygiene with dirty clothes in severe cases. Mood and affect characterized by low mood with feeling of hopelessness. They feel the future is black and dark, sometimes associated with anxiety and agitation in certain cases. There is also loss of interest in normal activity. Speech, there will be decrease in the amount and rate of speech. Maybe the depressed patient will take time or pauses before answering the questions, and maybe the interviewer need to repeat the questions many times before the patient will give answers or respond. In severe depression, they may have psychotic features in the form of auditory hallucination. Usually it's mood congruent, meaning that they are in harmony with the underlying mood and thoughts. For example, usually it is in second person auditory hallucinations, meaning that they are talking directly to the patient. For example, patient can hear voices telling him to kill himself. You should die. You are evil. You are a bad person. You deserve punishment. So it is in harmony with the underlying thoughts and mood. And then thinking. There will be pessimistic thoughts concerning the past, the present, and the future, as I explained earlier. May include worthlessness, hopelessness, helplessness, guilt. Guilt, sometimes it can be delusional. Like, for example, patient may believe that they are responsible for the poverty of the world, and they deserve punishment. So the criteria of a delusion will be there as a fixed, false, unshakable belief, firmly held by the patient, inconsistent with the patient's social, cultural, educational background, and cannot be corrected by reasoning. So all the criteria can be. So that's why you have to inquire on much more details, because if the delusion, if the guilt become to the intensity of the delusion, then it becomes a psychotic depression. Suicidal thoughts also may occur. Homicidal thoughts sometimes also present. For example, a depressed mother may decide the future is very miserable for her children, so she may take her children, she would decide to kill herself after and taking her children with her, meaning that to kill them and before she committing suicide. And as I mentioned, delusions can be happened in depression. Not only delusion of guilt, can be delusion of nihilistic delusion, delusion of poverty, delusion of illness. Like, for example, patient believes that she or he has a cancer, despite there is no any pathological evidence for this. In assessment of cognition, regarding orientation, most of the depressed patients are oriented to time, place, and person, although some of them may have not have enough energy to answer all these questions during the interview, but they are generally oriented. Concerning memory, 50 to 75% of the depressed patient may have cognitive impairment in the form of what we call it depressive pseudo dementia. So in which patient was complaining of impaired concentration and forgetfulness, especially in elderly. So this one, pseudo dementia, should be differentiated from dementia. So features supporting or suggestive of pseudo dementia include the sudden onset, the previous history of depression, downward variation of the cognitive problem, the presence of depressed mood, and giving I don't know answers whenever in response to questions, while in dementic people, they usually confabulate. And the symptoms are reversible and treated by antidepressant medications. The insight usually preserved, except in cases of psychotic depression or MDD with psychotic features. So in short, we can divide the depressive symptoms into 3 domains: emotional, physical, and cognitive. So for emotional, we have low mood, anhedonia, anxiety, irritability, hopelessness, suicidal thought, feeling of worthlessness, and excessive guilt. While the physical domains include insomnia or hypersomnia, loss of energy and fatigability, psychomotor agitation or retardation, low libido, appetite and weight changes, pain and constipation. While in cognitive domains, we have reduced attention, maybe poor concentration, difficulty of finishing tasks, and for example, inability to read, to complete one article or one topic, forgetfulness, inability to make decisions, and a reduced ability to think. Also, we have depressive stupor, in which the patient accepts features of stupor, being unresponsive, akinetic, mute, but fully conscious. And following this, the episode of stupor, the patient may recall the event that took place and depressed mood at the time. An episode of excitement may take place in between the episode of stupor. And because of the effective treatment of available, depressive stupor is very rare to be seen. So in assessment of depression, we have to take in consideration history, the presenting symptoms, the mode of onset, the duration and severity of the symptoms, number and severity of past episodes, any response to treatment, any hospitalization required, to assess psychosocial stressors, family history, suicidal attempt, past history of manic or hypomanic episodes, very important because the diagnosis can be changed from MDD to bipolar disorder. any history of substance or other psychiatric illnesses, social history and social support, and assess the social occupational functioning if there's any impairment. Then we have to take detailed medical history, including information about medication, prescribed medications, or do complete physical examination in order to assess to rule out any medical or surgical condition may cause or mimic depressive episodes. We have to do a proper mental state examination to include evaluation about this and severity of the depressive symptoms, look for the psychotic features, assess, looking for the risk of to harm suicide or harming other people. Then we have to do assessment of suicidal risk. This is very essential because the rate of suicide is high among the depressed patients. And in addition to the physical examination, we need to do laboratory tests, mainly to assess, because maybe the patient having severe weight loss, self-neglect, so need to assess the medical conditioning. Also, we need to do baseline investigations before starting giving medications that may have cause some changes. And of course, for the differential diagnosis, we do some diagnostic tests like thyroid function test to exclude any thyroid problems and so on. We will have one topic, one class for the suicide and deliberate self-harm, but it's worthy to talk here about the assessment of suicidal risk. Of course, some factors can increase risk, like loss of relationship, financial, occupational difficulties, poor social support, past suicidal attempt, family history of suicide, alcohol abuse or dependence, other comorbidities, suicidal ideation, severity of depression, presence of severe hopelessness, psychomotor agitation, low self-esteem, and of course, the past suicidal attempt is very important to look for details about this attempt and also about the patient intention at that time, suicidal intent. Moving forward to how to diagnose MDD based on DSM-5 criteria. So based on DSM-5 criteria, we should have 5 or more of the following 9 symptoms should be there, and with the period for at least 2 weeks, and it represents a change from the previous functioning. The depressed mood and loss of interest or loss of pleasure must be there among these 5 symptoms. So the point 1 is the depressed mood. Depressed mood should be for the most of the day, nearly every day, meaning that sebanjang hari setiap hari. So it should be differentiated from normal sadness. So it should be persistent for the most of the day, nearly every day for at least 2 weeks. It's either subjective, meaning that the patient telling you I'm feeling sad, hopeless, low mood, or it is observed by the others, meaning that the others can see that that person is tearful, crying. And in children or adults, that can be irritable. The second point, which is markedly diminished interest or pleasure, or what we call anhedonia, almost in all previous activities, pleasurable activities or the activities that the patient used to enjoy, either subjective or observed by others. Then significant weight loss without dieting or weight gain, and significant is 5% of body weight changes within 1 month. So either increase or decrease appetite nearly every day. Then we have insomnia or hypersomnia, psychomotor agitation or retardation, fatigue or loss of energy, and feeling of worthlessness or excessive guilt. And this guilt can be delusional. Decrease in concentration nearly every day and inability to make indecisiveness. It can be subjective or observed by others. And thoughts of death or suicide. It's not like fear of death, but thought of thinking of death wishes or suicidal ideation, and then recurrent suicidal thought or suicidal attempt, or there will be sometimes in certain cases specific plan for suicide. So we should have at least 5 out of these 9 symptoms for at least 2 weeks, and among these 5 there must be either depressed mood or at least either depressed mood or loss of interest or anhedonia. And these symptoms cause clinically significant distress to the patient and impairment in the social occupational functioning. And this episode is not caused by physiological effect of a drug or substance or any other medical condition. And the episode not better explained by other disorders like schizoaffective disorders, schizophrenia, schizophreniform, delusional disorder, or other psychotic disorders. And of course, there should be no history of manic or hypomanic episodes. Otherwise, the diagnosis will be bipolar disorder. So we have many specifiers in DSM-5 with the MDD, major depressive disorder. It can be with anxious distress, with melancholic features, with mixed features, with seasonal pattern, with psychotic features, either mood congruent or mood incongruent, with atypical features, and with catatonia, and with peripartum onset. Also, the severity of depressive episode can be measured, can be divided into mild, moderate, severe without psychosis, or severe with psychotic features. So in mild, the symptoms can enough to fulfill the diagnostic criteria, but it causes minor impairment in social occupational functioning. Moderate is in between the mild and severe. Severe without psychotic features. They have several symptoms that excess for the required to make the diagnosis, and the intensity of the symptoms is severe and causing severe impairment in the social occupational functioning of the patient. Then we have severe with psychotic features. So whenever psychotic features are there, delusions or hallucinations or sometimes both, it will be considered as a severe depression. So the first one is with anxious distress, meaning that it requires the presence of at least of the following symptoms during the period of depression. Feeling hiccuped up or tense, feeling unusually restless, difficulty in concentration because of the worry, and fear or something awful can be happened, and feeling that the individual may lose control of himself or herself. So this one, because an anxiety can be associated part of the symptoms of the symptoms, part of the MDD. So when these symptoms are present, DSM-5 allow us to diagnose this specifier. So it can be mild when we have only 2 symptoms, moderate 3, moderate to severe 4 or 5, and then severe when we have all these symptoms with motor agitation. The presence of anxious distress can be meaning that high level of anxiety associated with high level of increased risk of suicide, longer duration of the illness, and may be associated with the likelihood of treatment not in response or resistant. Other specifier, when we have depressed episode with mixed features. So we have MDD, but with at least of the three of the following manic or hypomanic symptoms are present during the MDD. For the criterion 1, elevated or expansive mood, inflated self-esteem and grandiosity, more talkative than usual, or feeling pressure to keep talking, flight of idea or subjective experience that thoughts are racing, increase in energy or goal-directed activity at socially or at work, school, or even increased sexual activities, then increase or excessive involvement in activities that have potential risk or very serious consequences, such as engaging in overspending, unrealistic overspending, sexual promiscuity, or unwise business. Then decrease need for sleep, feeling rested or despite just sleeping less hours than usual. The criterion B, mixed symptoms are observable by others, being a change from the previous usual behavior of the patient. And for the individual, those symptoms fulfill the criteria of mania or hypomania, then the diagnosis should be bipolar 1 or bipolar 2. And the mixed symptoms are not attributable to the physiological effect of any drugs or any other medications. So, meaning that we can diagnose depressive MDD with mixed features when we have only few symptoms of mania or hypomania to say that it is manic or hypomanic. Allow these symptoms enough to say that it is mania or hypomania, then the diagnosis is no more MDD. It's shifted to bipolar disorder, either 1 or 2. If full mania, then it's bipolar 1. If just hypomania, then bipolar 2. Other specifier, when we have psychotic features, what we call psychotic depression. So the presence of psychotic features reflect, as I mentioned, is a severe episode, and it has a poorer prognosis. The psychotic features can be categorized into mood congruent, meaning that in harmony with the underlying mood and thoughts. For example, as I told you that delusion of guilt, I deserve to be punished because I'm so bad, or hearing voices telling him that the patient is failure or better to die or should die. Mood incongruent, they are not in harmony with the underlying mood, like for example, other types of delusions. Okay, so that is not in the line with the underlying mood. So before saying that it's mood incongruent, MDD with mood incongruent, you should be careful to exclude schizoaffective disorder or schizophrenia. And those with the psychotic features may be in MDD with psychotic features, they require antipsychotic in addition to the antidepressant, or in certain cases they require ECT, Compulsive Therapy. Other specifier is with melancholic features. Melancholia is a very old term used in psychiatry. It describes the dark mood of depression. It is still used to reflect that you have severe depression. So the presence of melancholic features reflect a severe depression, which include early morning awakening, weight loss, profound feeling of guilt. So in DSM-5, melancholic features can be applied to MDD and MDD depression, and also in bipolar 1 and bipolar 2. So the DSM-5 criteria for melancholic features may include one of the following should be present during the severe period of the current episode: loss of pleasure in all or almost all activities, meaning that severe anhedonia, or lack of reactivity to the usual pleasurable stimuli. So doesn't feel much better or even temporarily when something good takes place. Then Criterion B, 3 or more of the following. Distinct quality of depressed mood, meaning that the depressed mood is experienced in different way, that feeling experience is very severe one, very severe depression. And then the depression is regularly worse in the morning, and we have early morning awakening. As I mentioned earlier, patient wake up 2 hours earlier than his usual waking up time. Marked psychomotor retardation or agitation, significant anorexia or weight loss, and excessive guilt. Other specifier is with atypical features, what we call atypical depression. So it include the following: mood reactivity, meaning that the mood improve a little bit in response to potential or positive event or good events. And 2 or more of the following: significant weight gain or increase in appetite, hypersomnia, and leaden paralysis, meaning that the feeling of heavy leaden feelings in the arms or legs, and a long-standing pattern of interpersonal rejection sensitivity. So they become very sensitive, that result in the significant social occupational impairment. And the criteria are not met for melancholic or with catatonic during the same episodes. So when the patient with major depressive episode with atypical features compared with those with typical features, those with atypical features, they have a younger age of onset, severe psychomotor slowness, and more frequent coexisting diagnosis of an anxiety disorder such as panic disorder and substance abuse or dependence and somatization disorder. That are specifier with catatonic features, in which characterized by at least 3 of the following: stupor or catalepsy, waxy flexibility, mutism, negativism, posturing, mannerism, stereotypy, agitation, grimacing, echolalia, echopraxia. So at least 3 of these 12 motor symptoms of catatonia should be there to diagnose the, along with the MDD, to diagnose MDD with catatonic features. And catatonia is not only in depression, can happen in manic episode, can be happened also in schizophrenia, and of course should exclude the organic causes of catatonia. Then with seasonal pattern, studies have shown that patients with seasonal pattern tend to experience depressive episodes during particular season, and most commonly during winter. So depression that develops due to shortening daylight in winter and disappear during spring and summer because there will be a prolongation of the daylight. The pattern became known as seasonal affective disorder, although this term is not being used in DSM-5. So major depressive episode can occur in seasonal pattern, is characterized by hypersomnia, overeating, weight gain, and craving for carbohydrates. So it's related to abnormal melatonin metabolism. So one of the methods of treatment is to exposure to bright light, artificial bright light during hours of darkness. The other specifier is postpartum onset. Severe depression beginning within 4 weeks of giving birth, mostly occurs in women with underlying pre-existing mood disorders or other psychotic disorder. The symptoms range from mild insomnia to irritability to labile and fatigability to severe cases that end with suicide. Homicidal and delusional beliefs may occur about the baby may be present, and can be psychiatric emergency in some cases for both mother and baby at risk. For the differential diagnosis, Depressive disorder should be differentiated from medical conditions that may cause depressive symptoms, such as Parkinson's disease, epilepsy, dementia, hypothyroidism, head injury, and also should be differentiated from substance-induced mood disorders like alcohol or drugs such as antihypertensive or even oral anti-contraceptive pills. And also depressive MDD should be differentiated from normal sadness. So in order to differentiate, we have to apply the DSM-5 criteria. Once it's fulfilled the DSM-5 criteria, then it's no more as normal variations considered as MDD. Because in normal sadness, it doesn't last for long, just lasts for a few days, compared to MDD, it should be at least 2 weeks. And the intensity is less compared to the MDD. Of course, we should exclude bipolar disorders by taking detailed history to look for any previous manic or hypomanic episodes. And schizophrenia, especially when we have psychotic features, because psychotic features can be happened in mood disorders, and also in schizophrenia we can have mood symptoms, but usually the mood symptoms in schizophrenia is not prominent, and delusions and hallucinations, when it happened in MDD, they are mood congruent. And usually it will improve when the mood is improved. And also we look for the detailed history, family history of, for example, family history of schizophrenia, more towards schizophrenia, family history of, and look for the premorbid history and the course of the illness. Usually the course of the illness in MDD is episodic. In between, the patient can return to the normal functioning, while the course in schizophrenia is chronic with multiple exacerbations and remissions. In between, the patient is affected and they're not returning to the baseline functioning, and with successive episode, the patient more have impairment in the social occupation functioning. This is in schizophrenia. Schizoaffective disorders. Most symptoms develop concurrently with the symptoms of schizophrenia, but delusion and hallucinations must be present for at least 2 weeks without prominent mood symptoms. So this is one of the important criteria of schizoaffective, to have psychotic features without mood symptoms for at least 2 weeks. And we should have the psychotic features, and which can fulfill a criterion A of schizophrenia concurrently with mood episodes. And usually these psychotic features are mood incongruent. So, and anxiety symptoms can be happened in MDD. So sometimes even mild depressive disorder is difficult to distinguish from anxiety disorders, but we should take detailed history to look which one is started first, whether these anxiety symptoms are part of the depressive episode, meaning that they are symptoms not enough to highlight anxiety disorders. Okay, so we have to look for which one started first, which one is more prominent. Then obsessive compulsive disorder, OCD. Depression is distinguished from OCD by its course, as obsessive symptoms associated with depression are only found in the presence of major depressive disorder, while true OCD persists despite remission of depression. Also distinguished or differentiated by determining which one started first, as OCD symptoms or obsessions can be happened as a symptom, can be happened in depression, but we have to look for which one started first, which one is more prominent, and also depressive symptoms can be part of the OCD. That's why it's very important to distinguish between them. It is also important to distinguish or to differentiate between MDD and grief reaction. So in grief, the predominant effect is feeling of emptiness and loss, while in MDD, persistent depressed mood and inability to anticipate happiness, or what we call anhedonia. The dysphoria in grief decrease in intensity over days to weeks and occurs in waves, what we call bands of grief. And these waves tend to be associated with thoughts or reminder of the deceased, while the depressed mood in MDD is more persistent and not tied or specific to thoughts or preoccupations. In grief, the pain is accompanied by positive emotion and humor, while in MDD, the pervasive unhappiness and feeling misery. In grief, thought content, preoccupation with the thoughts and memories related to the deceased, while in MDD, more to have pessimistic thoughts and ruminations and self-critical thoughts. Self-esteem is generally preserved in grief, while self-esteem is affected and feeling of worthlessness in MDD. Concerning thoughts of death in grief, generally focus on the deceased and joining the deceased, while in MDD, focus of ending one's life because of feeling worthless, unable to cope with depression, rather than is related to the deceased in grief. Moving forward to the management of MDD. So far, any question concerning MDD?
Doctor, I have a question. I came across the term clinical depression. What does it mean? Is it a subtype?
Clinical?
Clinical depression.
Okay, actually, this is clinical. Is maybe a term can be used to either to clarify about or to represent a significant depression, meaning that it's not only symptoms, but maybe it highlighted is that affect the patient is enough to fulfill the DSM-5 criteria, but it's not commonly used as a because it's a depression is a depression. It should be fulfilled in order to diagnose depression. It should fulfill the DSM-5 criteria. But sometimes they call subclinical when the features of depression are very mild. So may suggest for, but it not may fulfill the diagnostic criteria. Did I answer the question?
Yes. And then there's another one. What is the difference between suicidal thoughts and suicidal ideation?
Suicidal thoughts or ideation, I think, represent the same, that it's the idea of wants to kill oneself. But it should be differentiated between active suicidal thoughts from passive suicidal thoughts. Passive suicidal thought, or what we call death wishes. I wish to die, but I have no plan or to kill myself. Okay? So we have active suicidal thoughts and we have passive suicidal thoughts or death wishes.
All right, thank you, Doctor.
Most welcome. Okay. So for the treatment of MDD, this algorithm is based on the latest CBG for treatment of depression. So you can see here, we have the treatment is divided into two phases, acute and then continuation and maintenance. Sometimes in certain books divided into three, acute, continuation, and maintenance. Okay, so for acute, we based on the severity of depression, mild, moderate to severe, and severe with psychotic features. So mild to moderate, so the treatment is a psychosocial intervention plus psychotherapy may be required to give pharmacotherapy, meaning that antidepressant. Okay, while moderate to severe, there is pharmacotherapy, psychotherapy, and psychosocial intervention, and sometimes we need ECT. While in psychotic, MDD with psychotic features represent a very severe, also severe MDD with psychotic features, there will be pharmacotherapy, plus psychosocial intervention, and sometimes we need ECT. Then we give continuation, and of course, the acute treatment is to achieve remission, meaning that resolution of the symptoms. Then the aim of continuation and maintenance is to prevent relapse and recurrence of the depression. So continuation and maintenance include pharmacotherapy plus psychosocial intervention, or sometimes psychotherapy plus psychosocial intervention without pharmacotherapy. So it depends on. But usually, the treatment, it follows the acute treatment, meaning that we maintain the same treatment that improves that result in the remission of the symptoms. We maintain the same treatment for the continuation to prevent relapse or recurrence of the depression. So when we have the diagnosis of MDD, so we consider some factors related to the choice of antidepressant. So there are many factors based on the patient's general health and the symptoms of depression, okay, whether we need sedation or not, because of there are different antidepressants with different profiles. So we generally start any one of the second generation antidepressant. So the second generation antidepressant can include selective serotonin reuptake inhibitors such as fluoxetine, citalopram, paroxetine, fluvoxamine, and sertraline. Or we can start with serotonin and norepinephrine reuptake inhibitors such as, for example, duloxetine and vilamaxine, or NASA such as mirtazapine or melatoninogenic antagonist, and or also a serotoninogenic antagonist. So there are different types. These all, anyone can be used based on the CBG. Depends on the patient profile. If you want sedative, for example, antidepressant, we can use mirtazapine. Okay. Then we start with antidepressant. We see the response between 2 to 4 weeks. If there is no response, we have to consider factors that may affect initial treatment failure, meaning that we may look for the, let's say, the factors can be poor compliance, maybe comorbidity, maybe organic conditions, maybe you missed the diagnosis, incorrect diagnosis, failure to find the psychotic features, okay? Maybe you have personality issues, or we have severe or adverse psychosocial factors. So you have to deal with these things. If good response, then we do there will be go for the phase of remission, and then we go for the continuation and maintenance for 6 to 9 months. Or sometimes we have to continue for more than 2 years if there is severe high risk of relapse or recurrence. So if we assess if there is no response, so we consider these, look for these factors that we mentioned earlier and manage accordingly. Then optimize the dose. If there is no response, so adequate response after 2 weeks, then we go for other strategies. Either we switch to another antidepressant with different class, or we do combination treatment with or augmentation. with maybe atypical antipsychotics or with mood stabilizers like lithium. Okay. If there is a good response, then we continue for the remission phase and then continuation. So we achieve remission and then continuation with the maintenance. ECT, electroconvulsive therapy. There are few indications to use ECT in depression when we have very severe symptoms with functional impairment, when we have severe psychotic symptoms, catatonic features, and urgent for response for life-threatening conditions such as refusal to eat or highly suicidal risk due to depression. So again, this figure will represent the phases of a treatment of MDD. So here we have the symptoms. So you can see that when we start antidepressant, our aim is to achieve remission. So you can see that this is the started the treatment. This is the acute phase. So now you can see that these are the symptoms. We have the progression of the disorders. So now we have here, we can diagnosis of MDD. So we start the treatment. So the acute treatment may last up to 12 weeks. The aim is to achieve remission. So you can see here, when it started treatment, there will be symptoms improve until resolution of the symptoms. So now, normalcy, within normal. So now when we reach this, meaning that we achieve remission. This is the response of a treatment. Until here, we reach the remission. So whenever we reach remission, then symptoms, no more symptoms, and patient now appear to return to the baseline functioning. So the acute phase is already done. So now we enter to the continuation and maintenance. So your continuation usually for 6 to 9 months after achieving remission in order to prevent relapse. Relapse meaning worsening or appearance of the symptoms after initial improvement. So after 9 to 6 months from this, then we can see that there is no any relapse, then it will be recovery. Recurrence happened when after a while, if the patient will maybe, for example, having previous episode, more than 2 episodes, or there are still psychosocial factors that may predict for relapse or recurrence, then we have to give maintenance treatment to prevent recurrence. Okay. So now we can conclude that we have acute phase to achieve remission, continuation to prevent relapse, and maintenance to prevent the recurrence of the depressive episodes. Is that clear?
Yeah.
Okay. So the treatment of depression is biopsychosocial spiritual. And the treatment involves biopsychosocial investigations and biopsychosocial, biopsychosocial spiritual treatment. So for investigations, as I mentioned earlier, biological intervention, biobiological investigations, either diagnostic or to assess the general baseline of the function, meaning that diagnostic like thyroid function test and the baseline is before starting the antidepressant or sometimes even antipsychotic with the psychotic depression, and also to assess the general condition, health condition of the patient. The psychosocial may include assessment, taking collateral history, tracing previous records of patient having previous admissions or previous episodes or previous treatment. Also to assess the severity, we can use some certain tools that these tools are helpful in the assessment of the severity, like Beck Depression Inventory can be helpful to assess the severity. It's not diagnostic, but it can be helpful tool. Or we can use DAS, Depression and Anxiety Stress Scale, or any other scale that should be validated to assess as a screening tool and to assess the severity. Also, the most important part is to assess the suicidal risk. Then spiritual, to assess the knowledge, practice for their religion and the spiritual aspect and the morals in relation to the disorder. Then we go for the treatment. Again, it's biopsychosocial, spiritual, so biological, can be, as I mentioned earlier, with the antidepressants. Sometimes we need antipsychotics in case of psychotic depression. And in certain cases, we need ECT. And the duration or the phases of the treatment, acute phase, and also continuation phase and maintenance phase. Then this is biological part or pharmacological aspect. Then psychosocial aspect include psychoeducation. Psychoeducation for the patient and the family mainly to improve the insight and awareness about the illness and about the etiology, the course of treatment, and duration of the treatment, possible side effects, and also importance of continuation taking the medicine and medication and coming for the follow-up, and of course to prevent the relapse and recurrence. Then we have assurance, supportive, and problem-solving treatment attacked by focusing identification and resolution of the current life difficulties, and give the patient opportunity for ventilation of emotion and problem-solving. And of course, the specific one is the cognitive behavioral therapy is very effective in the treatment of MDD, providing that the patient is psychologically minded and with good insight. And the goal of this therapy is to remove the negative thoughts or negative cognitions that I mentioned earlier, negative view about the self, the future, and the present, and help the patient to develop more flexible and positive way of thinking. Then interpersonal psychotherapy is a brief psychotherapy focused on improving the patient's interpersonal functioning by identifying the problem associated with the onset of the depressive episode. This therapy is based off two assumptions. The first, current interpersonal problem are likely to have their roots in early dysfunction of relationship, and the current interpersonal problem is likely to be involved in precipitating and perpetuating the current problem. That's why this aim to improve the interpersonal relationship or the function of the patient. Family intervention is very important because depression can affect the family stability. And also when the depression is related to family stressors or family problems, so need to do family intervention in order to prevent the perpetuating problem. Physical exercise is very important because it's found that many studies that exercise can help in improving depression and increase this problem of self-well-being. Regarding the course and prognosis, the unipolar depression MDD may start at any time from childhood to late life, but the mean age of onset is about 40 years of age. Untreated depressive episode may last about 6 months or more. With treatment, each episode will last 2 to 3 months on average. Most of patients eventually recover from the episode, although recurrence is very common, and half of those who have a single episode followed by complete recovery will eventually have another episode. Unfortunately, 10 to 15% commit suicide. So good prognostic factors when we have mild episodes, absence of psychotic symptoms, short hospital stay, and psychosocial indicator of good response may include history of solid friendship during the adolescence, stable family condition, and also having good or proper social functioning for the 5 years earlier to the illness. Absence of comorbid psychotic disorders and anxiety disorders, not more than one previous hospitalization for MDD or episode. While poor prognostic factors may include comorbid dysthymia, history of more than one previous depressive episode, presence of psychotic features, comorbid anxiety disorders, comorbid or previous history of drugs or alcohol. Men are more having poorer prognosis, and history more than previous depressive episodes. Any question concerning MDD before going to the dysthymia?
I have a question regarding the association or the correlation of the MDD and also the prognosis and the effects of abuse, like substance, drug, or alcohol. Is it like also towards habits, kind of thing, like gambling addictions or sexual promiscuity addictions, something like that?
Okay, any comorbidities that affect personality, affect comorbidity with drugs, comorbidity with other psychotic disorders, make the prognosis poorer, affect the prognosis. And of course, history of drugs or any gambling that you mentioned or any addiction can make the prognosis much poorer.
All right, thank you.
Most welcome.
Doctor,
Yes.
for a treatment of major depression, so ada therapy, I mean like pharmacotherapy, right? So
Yes.
we need to achieve remission, and then we want to maintain, right? So
Yes.
when do you decide that you want to cease giving medication to patient?
When I decide what? Sorry?
To cease giving medication, or does the patient have to take the medication lifelong?
Okay, it's a good question. For the first episode, okay, when the patient develops MDD, just follow this one. The treatment is usually divided into acute and continuation, okay? Acute to achieve response, to achieve remissions, meaning that remission, disappearance of the symptoms and patient return to the normal functioning. Now, no more features of depression, able to function. But still, we have to give continuation treatment for at least 6 to 9 months to prevent relapse. But certain patients require to have more than this for at least 2 years, for example, when the possibility of having recurrent episode is high. For example, having more than 2 episodes previously. Still presence of psychosocial stressors that precipitating previously depressive episode not being dealt with. Okay, so there are certain points that you have to take in our consideration. So when we think that there is a possibility of recurrence, then we have to extend the time, at least 2 years, for example. So it depends on from patient to patient, how many previous episodes, social support, response to treatment, many factors. But generally, for first episode, we give treatment after resolution of achieving remission, continuation of 6 to 9 months until to prevent relapse. Did I answer your question?
Yes, Doctor, thank you.
Most welcome.
Doctor,
Okay.
is there any specific time frame when we can say that the patient is fully recovered?
Sorry, is there any
time span that we can say that this patient actually have fully recovered? Because, for example, if the patient already entered the continuation and also maintenance phase, and then there is no recurrence or relapse for about 5 to 10 years, for example, can we say that this patient already fully recovered?
definition of recovery is meaning that you give enough time to the patient with much treatment. That is, as I mentioned earlier, when you give treatment, you give to 3 weeks for the acute treatment, and then 6 to 9 months after achieving remission as a continuance, there is no symptoms and the patient is still able to function as well, so this is the time to say it's recovered. Okay?
Okay.
So you have to follow up the patient. That's why when achieve remission, for example, we see the patient initially during this phase. Can you see my arrow now?
Yes.
Okay, usually when the symptoms started, it's like this, the progression of one. Usually we see the patient here, right? So when you see the patient here, we started medication and treatment in general, biopsychosocial, spiritual, right? So when you start your treatment, our aim is to get a good response. So when we start the antidepressant, we continue follow up the patient. Of course, here more frequent. Let's say we start here, we see after 1 week, and then maybe in an interval of 2 weeks, we continue to see the patient. Now, this is a good response. We mean that almost 70 or 75% of the symptoms subsided. So we can see now we are achieving a good response, and then we continue until here, remission. Remission meaning that no more symptoms and the patient able to function as usual. Okay, so here we can say that we achieved remission. We cannot stop here. What happened if we stop here? We will have relapse. That's why we have to give continuation treatment. Again, 6 to 9 months here, we have to give continuation treatment to prevent relapses. Relapses meaning that reappearance or worsening of the symptoms after initial improvement. So if 6 to 9 months, patient the symptoms after remission, this period, no symptoms, able to function well, then this is the time to say it is recovered. Then we plan to stop the medication. When we stop the medication, we stop gradually to avoid antidepressant withdrawal and to avoid the side effect. And we still monitor the patient until the patient is okay, no problem. Then we discharge the patient. Okay. But sometimes patients require much more because of previously the previous episodes. So we expect that if we not give maintenance treatment, the patient will have recurrence. Recurrence meaning have another episode. So that's why we give maintenance treatment based on the patient history. There is no fixed rule. Sometimes very long duration, sometimes 2 years. It depends on many factors, environmental factors, individual factors, okay, comorbidities, and the Manic issues. Okay, but here, when you give, just to focus here, when we give achieve remission about certain dose, it's better when you do continuation with the same dose. Okay, faham?
Okay, faham doktor.
Okay. Okay, moving forward, do you need a rest or we continue until we reach bipolar? We take a rest 5 minutes. Continue?
5 minutes.
5 minutes, huh? Okay, we take 5 minutes rest.
All right.
Okay, can we start again?
Right.
Okay, so this time, yeah, dysthymic disorder is characterized by at least 2 years of low mood. It's not sufficient severe to fit the diagnosis of MDD. The most typical features of dysthymia is known as persistent depressive disorder is the presence of depressed mood that is less or more days than not and present continuously. And there are associated feelings of inadequacy, guilt, irritability, anger, withdrawal from society, loss of interest, inactivity, and lack of productivity. So for the diagnosis and clinical features based on DSM-5 diagnostic criteria of dysthymia, required the presence of the depressed mood for most of the time for at least 2 years, or 1 year for children and adolescents. And to meet diagnostic criteria, the patient should not have symptoms that is better accounted for the MDD and should never have the manic or hypomanic episode. But DSM-5 allow the physician to specify whether the onset is before the age of 21 or after the age of 21. Also, DSM-5 allows specification of atypical features in dysthymia. And the essential core of dysthymia include habitual gloomy and lack of joy in life, preoccupation with inadequacy, and dysthymia is characterized by long-standing, fluctuating, low-grade depression. So in DSM-5, this disorder present, previously in DSM-4, there will be 2 disorders as chronic major depressive disorder and dysthymic disorder. So in DSM-5, it has been compiled to become a persistent depressive disorder to consolidate the 2 other disorders in DSM-4. So persistent depressive disorder, dysthymia, in DSM-5 is characterized by depressed mood for most of the day, nearly every day, either subjectively or observed by others for at least 2 years, but in children it can be irritable mood and may last for 1 year. And the presence in addition to the low mood, 2 or more of the following should be there: poor appetite or overeating, insomnia or hypersomnia, low energy or fatigability, low self-esteem, poor concentration or difficulty in making decisions, and feeling of hopelessness. So there must be low mood for at least 2 years. And then in addition to the low mood, 2 or of these 6 symptoms must be there. Criterion C, during these 2 years or 1 year of adolescent or childhood, the individual never have been without the symptoms in the criterion A and B for more than 2 months, meaning that it's continuously low mood, continuously these symptoms for 2 years, apart from the maximum without these symptoms, 2 months. And the criterion for MDD may be continuously met for 2 years. And never being manic or hypomanic or cyclothymic disorder. Then the discernment is not better experiences or explained by schizoaffective disorder, schizophrenia, delusional disorder, or other psychotic disorders, and not attributed towards the physiological effect of substance or any other medical condition such as hypothyroidism. And these symptoms should cause clinically significant distress to the individual or the patient and impairment in the social occupational functioning. Of course, we have the same specifier with anxious distress, mixed features, melancholic features, atypical features, mood congruent or incongruent, and peripartum onset, and whether into partial remission or full remission. And also the onset before the age of 21 or after age. And there is a very important specifier for the most recent last 2 years of persistent depressive disorder. Either we have with the pure dysthymic syndrome, meaning that the full criteria of MDD never being met during the last 2 years, or with persistent major depressive disorder episode, meaning that full criteria of major depressive episode have been met throughout the preceding 2 years, or with intermittent major depressive episode with current episode, meaning that full criteria of MDD are currently met, but there have been periods of at least 8 weeks in the last preceding 2 years with the symptoms below the threshold of MDD, or with intermittent major depressive episode without current episode, meaning that full criteria for major depressive episode are not met currently, but it has been one or more major depressive episode during the last 2 years. And also severity, mild, moderate, severe. Double depression is a term can be used when we have, let's say, they meet criteria for dysthymia in combination with MDD. So about 40% of patients with MDD also meet criteria of dysthymia. This is what we call it double depression, although it does not appear in DSM-5. So the patient with double depression have poorer prognosis than those with only MDD. The treatment of double depression should be directed towards both disorders because the improvement of the symptoms of MDD still leaves the patient with significant psychiatric impairment. Concerning the course and prognosis, about 50% with dysthymic experiences have insidious onset for the symptoms before the age of 25. About 20% progress to MDD, 15% bipolar 2 disorder, and less than 5% to bipolar 1 disorder. The prognosis of the patient with dysthymia varies. Antidepressants such as selective serotonin uptake inhibitors and cognitive behavioral therapy have positive effect in the course and treat good the prognosis of dysthymia. But 25% of all patients with dysthymia never attain complete recovery. Overall, the prognosis is good with the treatment. So in the treatment, again, the same like depression, biopsychosocial, spiritual, and the combination of pharmacological therapy is effective in the treatment of the disorder. So the psychological intervention may include CBT with the cognitive part and the behavioral part, and interpersonal therapy. Also, is the same like in MDD, the patient's current interpersonal experiences and the way of coping are examined to reduce the depressive symptoms and improve self-esteem. And then we have the pharmacotherapy or pharmacointervention. Generally, we use the data supporting the use of selective serotonin uptake inhibitors and SNRI, such as Villa vaccine or propion, more choice. Effective treatment for the treatment of patient with dysthymia. So different types of antidepressant, different group. Propion is another acting on dopamine. Villa vaccine or SNRI or SSRI have been effective in the treatment of dysthymia. Other insight-oriented psychotherapy based on the psychoanalytic intervention. It attempts to relate the development on maintenance of depressive symptoms and maladaptive personality features to unresolved conflicts from early childhood. So insight into depressive equivalent, such as substance abuse or into childhood disappointment as antecedent to adult depression may precipitate or predispose to adult depression can be gained throughout this treatment. So ambivalent current relationship with the parents, friends, and others in the patient's current life event are examined. Okay, so now moving forward to bipolar disorders. It's been based on DSM-5 is classified into bipolar 1, bipolar 2, cyclothymia, rapid cycling, substance or medication-induced bipolar-related disorders, bipolar and related disorder due to another medical condition, other specified bipolar disorder, and unspecified bipolar and related disorders. So bipolar disorder, patient with both manic and depressive episode, or patient with manic episodes alone are said to have bipolar disorder. So bipolar 1, in which mania episode has occurred at least once. Bipolar 2, in which hypomania has occurred, but mania has not. So the diagnostic criteria for bipolar 2 disorder is characterized by depressive episodes and hypomanic episodes. And during the course of the disorder, but there is no manic symptoms, manic episode. If there is manic episode, then it will be bipolar 1 disorder. While cyclothymic disorder characterized by the presence of symptoms that is less severe than bipolar 1 disorder and characterized by at least 2 years of occurring hypomanic symptoms that not fit the diagnosis of hypomania or mania episode, with depressive symptoms that cannot fit the diagnosis of MDD. So it is alternating, 2 years of alternating between hypomanic symptoms, not enough to highlight hypomania or diagnose hypomania or mania, alternating with depressive symptoms that not enough to highlight or to fulfill depressive episode. Then we have rapid cycling, which is defined as 4 or more affective episodes fluctuating between mania and depression, occurring within 1 year, and that episodes are separated by a period of remission or switch to another episode of opposite polarity. If having different episodes, for example, from depression to mania. So for the clinical features of mania, so the core features of mania when we have elevated or expansive mood, meaning that the patient is feeling elated mood. For example, patient may say that the feeling on the top of the board, or sometimes irritable, and it's associated with increase in goal-directed activities and increase in energy. Patients become sometimes angry when they have demands and their demands not being implemented. Also, there will be increased energy overactivity, increase over talkativeness, and there will be pressure of speech. Pressure of speech meaning that the patient's speech is loud, fast, difficult to interrupt. Also, there will be affecting sleep. There will be decreased need for sleep or reduced sleep need, meaning that the patient will wake up early, feeling lively, energetic, despite sleeping only 2 to 3 hours per night. I feel fully energetic during the next day. And while awake, he will or she will involved in such activities like physical activities, such as, for example, in the middle of the night, the patient may do house chores or doing physical exercise. Okay, and sometimes it's very annoying to the others, the family members, or even the neighborhood. Okay, then sexual desires are increased, and the patient may be patient's sexual behavior become disinhibited, and sometimes they involved in sexual promiscuity. They involved in also sometimes unsafe sex. So it may lead to serious consequences, such as they can lead to HIV or sexual transmitted diseases, or even sometimes the women can neglect their precautions, so they lead to some pregnancy, in certain cases. There will be poor attention span and then poor concentration. During manic episode, the patient may become spending unwisely their money. They are overspending. And then they have sometimes involved in unrealistic projects. They become maybe increasing goal-directed activity, maybe consist of excessive planning, participation in different activities, whether it is related to sexual or even work, political, religious activities. As I mentioned, will be increased sexual drives or fantasies, and then individual maybe become over social. Like, for example, they try to approach old friends from adolescent or during childhood period. They try to approach them, even there is no need to contact them, but they will do so. They sometimes they started to become over social in the form of making too many WhatsApp group, for example, calling many people, even strangers, to be involved in these groups and asking them to actively involved and so on. So they become much more, even sometimes this lead to some restlessness when the other people not implementing this, so they become angry. Other people, they have pathological gambling, and sometimes they become, even the dressing can be affected. They maybe they are not matching. They will go very bright colors, but the females will go excessive makeup, excessive jewelry they wear, and maybe sometimes they become aggressive and violent behavior. They may at times be occupied with thoughts related to the persecutory ideas, maybe sometimes it's reaching up to the delusional intensity. In severe mania, maybe have the severe and sustained physical activity and excitement that lead to severe consequences. They may be involved also in reckless behavior. They may be involved in races or some activities that have serious consequences, or they will have many projects or idea to involved in business that is, it's not well planned, or the patient doesn't have any previous experience or knowledge about it. They start maybe different projects that are related to his or her specialty, and ultimately they will lose their business. During mental state examination, the appearance may be dressing, the bright colors with inattention to the personal appearance, or sometimes even bizarre combination of clothes, excessive makeup, and sometimes in very severe, they become untidy. Facial expression the patient may look happy, or sometimes irritable, hyperexcited, sometimes even suspicious or threatening. They become sometimes more overactive. Sometimes they have persistent overactivity leading to physical exhaustion. During interview, they become over-friendly, and sometimes they are disinhibited. Their speech, they become over talkative or pressure of speech. You cannot interrupt them. They speak loud and fast. The mood, elated mood, or sometimes irritable or angry. They have low frustration tolerance, easy to become angry. And sometimes they have emotional lability, so switching from laughing to irritability to depressed within 1 minute or within even few minutes. Regarding thoughts, they have flight of ideas. It's very common. Flight of ideas, meaning that rapidly thoughts moves from one to the other, and before finishing the first one, the second one will come. And certain things that sometimes they are connected, the normal logical sequence of ideas generally preserved, but sometimes they are linked by distracting cues from the surrounding, or it's in relation to the words that have been spoken. This leads to, for example, a clanged association with a combination of unrelated words or phrases simply because they have similar sounds, not related to the logical meaning. Expansive ideas are common. They believe their ideas or thoughts are original. Their opinion should be taken seriously. and they have outstanding works. They are the best to do that job, and sometimes they become associated with delusions, like, for example, usually it's mood congruent. The patient believes they have extraordinary power, grandiose delusion, they have extraordinary power or ability to do certain things that other people cannot do. And sometimes they act on that. And when other people are not following this or not accepting this or rejected by other people, they become angry and sometimes even aggressive behavior. Also, they may have perceptual disturbances in the form of hallucinations. They can hear voices telling them that, for example, you are the best person in the world, or visual hallucinations, seeing themselves enthroned or as a religious figure. So they feel that it may also, that sometimes they are hearing voices telling them that you are king, you are prophet, something like this, or direct connections with the God in certain cases. Okay. Regarding cognition, the attention, concentration are affected because of easy distractibility, and insight usually impaired during manic episode. In bipolar 1 disorder, when having met the criteria of manic episode, at least one, meaning that you can diagnose bipolar 1 even the patient only having manic episode without depressive episode. But the most important that the patient already have at least one manic episode. So the current or most recent episode can be hypomanic, can be recent manic episode, whether it's mild, moderate, severe, or with psychosis, or bipolar 1 disorder currently in depressive episode, mild, moderate, severe, severe with psychosis. And we have to specify with anxious distress, mixed, or rapid cycling. So bipolar 1 shortly should have at least one manic episode. Then we diagnose bipolar 1 disorder. But the current episode can bipolar 1, currently hypomanic, manic, or depressive episode. While bipolar 2 disorder, having met the criteria of hypomanic episode at least once and major depressive episode at least one, and never ever being any manic episode. Otherwise, if there is any manic episode, then it will be bipolar 1. And then specify whether currently hypomanic or depressed. But it says specifier again with anxious distress, mixed features, or rapid cycling. So the DSM-5 criteria for bipolar disorder. Bipolar 1 disorder, then it must be fulfill the criteria of manic episode. So the manic episode characterized by, or the DSM-5 criteria, there will be distinct period of abnormally or persistently elated, expansive or irritable mood, and then with increased goal-directed activity or energy for at least 1 week duration. That present for most of the day, nearly every day. And during this period of mood disturbances, there must be 3 or more of the following 7 symptoms if the mood is elated, or at least 4 if the mood is irritable. So what are these 7 symptoms? Inflated self-esteem or grandiosity. Just as we explained earlier, can be, for example, I'm the best student, I'm the best lecturer, I'm the best teacher. This is inflated self-esteem. While a grandiose delusion can be any form of fixed false belief of ability to do certain things that other people cannot do. For example, patient either its ability or identity. For example, ability for a person with, let's say, with very low educational level, believing that he has the cure for COVID-19. Okay? or a patient believes, this is ability, or identity, patient believes that he is a prophet and sent by God and has a certain, as is a messenger, have certain a mission to do. Then decreased need for sleep. I described earlier that the patient is satisfied with sleeping only 2 to 3 hours of sleep, and on the next day he feels or she feels fully energetic, and should be differentiated from insomnia. Insomnia is an ability to fall asleep or disturb sleep or early morning wakening. Okay, here the patient feels that there's no need for sleep, and instead of sleep, he or she will engage in other goal-directed activities such as doing house chores or planning for many projects and so on. More talkative than usual or pressure to keep talking, flight of ideas or pressure of or thoughts are racing, distractibility, so the attention is being drawn to unimportant external stimuli, increasing goal-directed activity, that's sexually or socially or at work or school, then or psychomotor agitation, excessive involvement in activities at the level of that have high potential or painful consequences, such as engaging in buying sprees or spending, sexual promiscuity, or foolish business investment. Then these disturbances is causing severe impairment in the social occupational functioning, or in certain cases, severe cases require hospitalization to prevent harm to the person, to the patient, or others. And the episode is not attributable towards physiological or effect of substance or another medical condition. And these are the most important. So all these are the diagnostic criteria. So in order, you have to have the A, B, C, D criteria in order to diagnose the manic episode. While hypomanic episode, so it is also distinct period of abnormally or elevated mood, or irritable mood that persistent for at least 4 consecutive days, while in mania, 7 days. Okay, and during this period, there will be increase in during this period at least 3 of the 7 symptoms if the mood is related, or 4 if the mood is irritable. So the same, almost the same symptoms, but at less intensity. So inflated self-esteem and audacity, decreased need for sleep, flight of ideas. But Criterion C, the episode is associated with unequivocal changes in the unequivocal, meaning that it is mild or not causing change, severe changes or impairment in the social occupational functioning. And the episode is not severe enough to highlight indication for the hospitalization. And of course, there will be no psychotic features present. And the episode is not caused by physiological effect of under physiological effect of drug or medication or another medical condition. So now, in short, how we can differentiate between hypomania and manic episode? Anybody can take a chance to answer this question? Anyone want to try? Hello? So how we can, yeah, can you try? How we can differentiate between manic and hypomanic?
Based on the severity, doctor?
Okay, So manic episode is more severe than hypomanic episode. So you start to duration, right? So what's the duration for hypomania? At least
It is 4.
4 days. While for mania,
1 week.
1 week.
1 week.
Okay. Then psychotic features can present in manic episodes, while in hypomanic, no psychotic features. And hypomanic doesn't require hospitalization, while in mania may require hospitalization. And regarding the function,
The hypomanic is high enough, does not affect the function.
yes, in hypomania, the function is not being affected compared to the manic episode in which there will be severe impairment in social occupational functioning. So this is the way, and that's why most of the patients will come, usually manic not come to the clinical attention during hypomanic episode. Usually they come during manic episode. Okay, so a major depressive episode can be happened during the in bipolar disorder, whether it's bipolar 1 or bipolar 2. So it's characterized by 5 or more of the following 9 symptoms, and at least one of the symptoms, either 1 or 2, which is depressed mood or loss of interest, must be there. So again, this is the DSM-5 criteria we discussed before, and the symptoms cause a clinical significant distress or impairment in social occupational functioning, and the episode is not caused by the effect or substance of another medical condition. And we have a specifier with anxious distress, the same like we discussed before, and with mixed features. So the mixed features specifier can be applied to the current manic, hypomanic, or depressive episode. So manic or hypomanic episode with mixed features, when a full criteria met for manic or hypomanic episode, and at least 3 of the following symptoms are presented during the majority days of the mania or hypomania. What we have, at least 3 of prominent dysphoria or depressed mood, as indicated, either subjective, when someone telling you I'm feeling sad or feeling empty, or observed, like someone is very tearful and crying. Then diminished interest or pleasure, or what we call anhedonia, in almost all activities, either observed or subjectively mentioned. Psychomotor agitation, nearly every day, observable or subjective. Fatigue or loss of energy, feeling of worthlessness or excessive inappropriate guilt, and recurrent thoughts of death or recurrent suicidal ideation without specific plan, or with suicidal attempt or specific plan for committing suicide. This is for criterion A. So should be, we have during the manic or hypomanic, we have at least 3 out of these 6 symptoms. Then criterion B, mixed episodes are observed by the others, represent a change in the patient's usual behavior. And for the individuals or symptoms full episode of both mania and depression, simultaneously, the diagnosis should be manic episode with mixed features due to the marked impairment in the social reactivity or severity of full mania. And the mixed episode is not being attributed towards physiological effect of substance or drugs. While depressive episode with mixed features, then the full criteria met for major depressive episode, and at least 3 of the following manic or hypomanic symptoms are present during the depressive episode, either elevated mood or inflated self-esteem and audacity, more talkative than usual, flight of ideas, or racing thoughts, increasing goal direct activities, increase on or excessive involvement in activities that has serious consequences, and decreased need for sleep. So 3 out of these 7 And mixed symptoms observable represent a change in patient usual behavior. And for individuals, this is very important, whose symptoms met the full episode of mania and depression simultaneously, then the diagnosis should be manic episode with mixed features. And the mixed symptoms are not attributable towards the physiological effect of drugs or substance. Any question concerning the mixed episode? Is it clear?
Yes.
Okay. While rapid cycling specifier applied for both bipolar 1 and bipolar 2. In rapid cycling, we have at least 4 mood episodes in the previous 1 year that met the criteria for manic, hypomanic, or major depressive episode. But we have to note that episodes are decided either partial or full remission for at least 2 months, meaning that when we have similar episode, there must be a gap of 2 months without any features to say that it is another episode, or a switch to another opposite polarity, meaning that from depression to mania, this one doesn't require a period, just switch. So episodes are demarcated by either partial or full remission for at least 2 months, or a switch on episode to the opposite polarity. Differential diagnosis. So during a depressive episode, the differential diagnosis may include MDD, depressive disorder due to another medical condition, substance-induced depressive disorder, adjustment disorder with depressed mood, and anxiety disorders, and schizophrenia or schizoaffective disorder. While in manic or hypomanic phase, the condition should be differentiated from substance-induced bipolar disorder, bipolar and related disorder due to another medical condition like brain injury, schizophrenia or schizoaffective, and borderline personality disorder. Regarding course and prognosis, untreated manic episode last 3 to 6 months with a high rate of recurrence, average 10 recurrence. 80 to 90% of manic patients eventually develop full depressive episode. Then the recurrence rate is about 50% in 1 year. Mortality rate is high, with complete suicide rate about 10%. And the prognosis for 15 recover, 50 to 60 partially recover, meaning that we have multiple relapses with good inter-episodic functioning, and 1/3 have chronic symptoms with social and functional deterioration. So regarding the management, so based on CBG, when we establish the diagnosis, we have to assess the severity and decide the treatment, whether we are going to admit the patient or treat him as an outpatient or the community. Then acute phase management, and then also maintenance phase management for the follow-up. So this algorithm, when we have acute mania, we need to decide whether we can treat as monotherapy with either lithium or sodium valproate or carbamazepine, or monotherapy with either haloperidol or atypical antipsychotics, or a combination therapy with lithium or valproate or carbamazepine or haloperidol with atypical antipsychotic, meaning that when we have acute mania, we need to decide whether to treat monotherapy with mood stabilizer or treat monotherapy with antipsychotic, usually atypical antipsychotic, because it has mood stabilizer effect, or we need a combination therapy, mood stabilizer plus atypical antipsychotic. The decision based on many factors. Usually for the first episode, meaning that this is the first presentation, first episode, no previous treatment, we start with monotherapy for 2 weeks. If no response, then we either switch or we do combination. If the patient previously respond to a particular medication, we use the same. If they previously respond to a combination treatment, then we check the response of a previous medication. If good response to the side effect, then we continue with this. So this is the algorithm. So if no response within 2 weeks, we have either to switch to a typical antipsychotic. If we started with mood stabilizer, we add antipsychotic. If started with antipsychotic, we add the mood stabilizers. Then here we can replace one or both agents in step 1. Of course, we have to do psychosocial intervention is very important here. And sometimes we need ECT. Antidepressant should be discontinued. Why? Because antidepressant may precipitate manic episode. We may consider ECT in case of severe symptoms or intolerance or not responding to medication or high suicidal risk or student. So if the patient is already on treatment, so we consider optimizing of the current treatment. But we have to look for whether the patient is decompliance and if there is any side effect. So in treatment for bipolar depression, first line monotherapy, either lithium, quetiapine. Quetiapine, there are 2 types: immediate release, IR, or XR, extended release, or combination treatment like lithium or valproate plus SSRI, or olanzapine and SSRI, or lithium plus valproate, or lithium or valproate plus papaverine. The second line, valproate and lurasidone, if monotherapy, or combination therapy, quetiapine and SSRI, or adjunct lithium or valproate and modafinil. So modafinil can be used, lithium or sodium valproate, or we can use valproate and lamotrigine. Third line, monotherapy, carbamazepine, olanzapine, ECT, or combination, lithium and carbamazepine, lithium and valproate with venlafaxine, and so on. So meaning that usually we start with the monotherapy. Again, first we optimize the treatment of the mood stabilizers. If not, also we do a combination therapy. Now, good studies have been shown that good response with the lamotrigine in the treatment of a bipolar depressive episode. So the following medication can be used as monotherapy in acute bipolar depression: antipsychotic like quetiapine or olanzapine fluoxetine combination, lithium. Antidepressant may be used in short-term adjunct treatment in acute bipolar treatment, but should be under cover of mood stabilizer, cannot be used as monotherapy in the treatment of acute bipolar depression. Why? Because it can precipitate a manic episode. So if we say that in treatment of bipolar depression, you give antidepressant alone, it is false. Should be not given alone. Any question? So in addition to the, of course, again, the treatment of bipolar disorder, manic episode, or depressive episode, we start with the investigations. Investigation is biopsychosocial, spiritual, and investigation should include biological investigations to assess the general condition of the patient, and baseline investigation before starting the treatment, especially when if you are starting with the atypical antipsychotic or mood stabilizers, or even antidepressant. in case of you want to add antidepressant and mood stabilizer for case of bipolar depressive disorder. And psychosocial intervention, collateral history, trace the previous notes, scales can be used for the assessment of severity can be used. Then psychotherapeutic intervention, most patients, they have the current problem in the during bipolar disorder, problem associated with stigma, problem related to self-esteem, fear of recurrence, and effect of the disorder on the psychosocial functioning, interpersonal relationship problem, and issues related to marriage, family, childbearing, and parenting, academic and occupational problems, and other legal, social, emotional problems that may happen due to illness-related behavior. So what are the interventions? The psychoeducation and CBT. Psychoeducation is very effective, especially for any episode. We need to educate the patient about the illness to increase awareness, to improve our aim to improve the patient's insight, and then also to educate the family about the illness and educate about the treatment, because the most difficult one, how to persuade the patient to accept the management plan when they are not having, for the continuation phase, when they don't have the symptoms. So you have to explain that the symptoms can relapse if we stop immediately. That's why we have to give continuation and sometimes maintenance treatment. Also about the side effect of medications and importance of the compliance with the medication and coming for the follow-up. Also, interpersonal social rhythm therapy is very helpful for the treatment of bipolar manic episode and hypomania to reduce the liability of mood and by maintaining regular pattern of daily activities such as sleeping, eating, physical activity, and emotional stimulation. Family therapy, as mentioned, is very important for psychoeducation, and also any family intervention if we have any family issues, family conflict, and need to assess the family interaction, and we should have proper planning strategies for managing and reducing the family distress. Last topic is the cyclothymic disorder. So cyclothymic disorder, the essential features that it's chronic, fluctuating mood disturbances that lasting for at least 2 years duration. But in children, maybe it's less. It's maybe around 1 year. And it's characterized by hypomanic and depressive symptoms that never fulfill the criteria of hypomania or mania or a major depression. The female to male ratio is 3:2. 50 to 75% of all the patients have onset between the age of 15 to 25. And DSM-5 indicates the risk factor for cyclothymic disorders that having first degree relative with bipolar 1 disorder. And DSM-5 indicates cyclothymic disorders comorbid with drugs, substance abuse, and also because those with the cyclothymic, they tend to take alcohol or drugs to reduce the symptoms. Comorbidity also found with sleep disorders involving poor sleep onset, initial insomnia, and maintenance of sleep. Also association with attention deficit hyperactivity in children. It can cause impairment in social occupational functioning. And then social functioning may be affected by inappropriate behavior. And when individual with recurrent episode of the depressive of hypomanic symptoms may have difficulty in maintaining relationship or employment due to absence from work or poor performance. And disorders such as bipolar 1 or 2 with rapid cycling, and borderline personality disorders and substance abuse, and possible differential diagnosis. So a DSM-5 criteria for cyclothymic disorder for at least 2 years duration or 1 year in children or adolescent. There must be a period of alternating between hypomanic symptoms, that doesn't meet the criteria of hypomania episode, and periods of depressive symptoms that not following the criteria of major depressive episode. And during the above 2 years period, or 1 year in children or adolescents, the hypomanic and depressive symptoms have been persistent for at least half the time, that not more than 2 months at time, meaning that the duration of not having the symptoms not increasing than 2 months during these 2 years. And the criteria for major depressive, manic, and hypomanic episode never ever been met. And the symptoms of criterion A not better explained by schizophrenia, schizoaffective, or schizophreniform disorder or delusional disorder. And the symptoms cannot be attributed towards physiological effect of substance or other medication or any medical condition such as hyperthyroidism. And the symptoms causing significant impairment in the social and occupational functioning. And specifier, like for example, with anxious distress. So the treatment, again, is biopsychosocial, spiritual, biological, the use of mood stabilizers and anti-mania drugs is the first line of treatment with cyclothymic disorder. But the use of lithium can be helpful, and sometimes some studies have been shown effectiveness of Tegretol, carbamazepine, and sodium valproate is effective in certain cases. Then psychosocial therapy. Psychotherapy for patients with cyclothymic disorder is best directed towards increasing the patient's awareness of their illness and helping them to improve their coping strategies towards stress and how they can control emotional regulation to control the mood swings. And the therapist usually need to help the patient to repair any damage that happened to affect the work and relationship with the family members during these episodes. And family and group therapy can be helpful and supportive and maybe educational and therapeutic for the patient, for those involved with the cyclothymic disorder. And these are my references. So any question?
I have a question, doctor. Just now for MDD, we said the diagnosis can change to bipolar if we suspect they have hypomanic or manic symptoms, right? So if the patient is diagnosed with bipolar, and bipolar is when we have depressive and hypomanic or manic symptoms. So what if after a period of time, the patient doesn't show any hypomanic symptoms, but the patient still have the depressive symptoms? So can the diagnosis change back to just being as MDD?
No. Once the patient is having manic episode or having hypomanic episode, no, the diagnosis will become bipolar disorder. Cannot go back to MDD. So since a patient having, that's why it's very important. Let's say patient first presentation with depressive symptoms, okay, and then you diagnose as depression. So before saying that this is MDD, you have to take detailed history that the patient doesn't have any hypomanic episodes. Otherwise, the diagnosis will be, if there is a hypomanic episode, bipolar 2. Or manic episode, then bipolar 1. Okay, so the diagnosis from MDD, if the previous first episode MDD, no previous hypomanic or manic episode, diagnose MDD, but later on the patient develop hypomanic or manic episode, then no more MDD, now become bipolar disorder, but cannot return back to the MDD once since the patient having manic or hypomanic. Did I answer the question?
Yes. So even after a period of time, like, because it's like a cycle, right? So even if the hypomania is like very less, we still
Yes.
Okay.
Patient kind of presented manic episode. Bipolar 1, for example, manic episode, manic episode, manic episode, hypomanic, depression, 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 still the diagnosis, bipolar 1, but currently manic episode, currently hypomanic episode, currently major depressive episode, based on the current episode. Okay? Still bipolar.
Then for the bipolar patient, like how long is the follow-up continuation? Because for the MDD, we have the remission phase, right?
Okay, bipolar, it depends on the, that it can be, usually we all same like in depression, we see in acute management, okay, until we achieve remission, then we give continuation treatment, but it's a little bit longer. But sometimes, because bipolar have high rate of recurrency, that's why the possibility of having another episode is very high. So sometimes it's become lifelong disorder. You can see here from the prognosis, you can see the records. Okay, so you can see that the recurrence is about and at least average 10 recurrence. So it's very high. That's why you need to follow up the patient. Okay. So if the patient develop only manic episode, can we say that it's bipolar or not?
Only manic bipolar type 1. Can.
Good. Can. Okay. Any question? Any question? Okay. If you don't have any question, thank you very much for listening to my lecture. And we end our lecture with citation of Suicidal Aspects. Okay, thank you very much. Assalamu alaikum wa rahmatullahi ta'ala wa barakatuh. Stay safe.
Waalaikumsalam warahmatullahi
Thank
wabarakatuh.
you,
Thank you, Doctor.
Thank you, Doctor.
Doctor.